Hi everyone, my name is Adara and I am very excited to be hosting the February Academic and Life in Emergency Medicine Book Club, and this month we are featuring the book Bouncebacks by Dr. Mike Weinstock. This is a very exciting book and this is going to be a good discussion. We have 4 chief residents from the Academic Life in Emergency Medicine Chief Resident Incubator joining us, and in addition to that we have the author himself, Michael Weinstock. So if you're tuning in either by podcast or video, be sure to also go over to our blog and check out the synopsis that our chief resident, Zach Reisler, wrote himself. It's a great synopsis of the book and all the pearls that you should know when you're going to be reading the book, and just be sure to check it out. So I want to first start off by answering the question why we chose this book this month. And as you know, emergency medicine is full of a ton of emergency medicine resources, educational resources, where some are like, you should read this, a few are, I need to read this, but very few are, I must read this book. And I would say that this book is one of those must-read books. All providers should check this book out. And what it is, it's basically a compilation of about 30 cases, bread and butter, run-of-the-mill, everyday cases that you see, and Mike Weinstock and some colleagues pick apart all of the nuances, all of the pearls and pitfalls that are related to documentation and management, so that you can sort of take these lessons and weave them through your clinical care and become better providers. It's an excellent book, well put together, and I know why I love the book, but I want to ask Mike, why did you decide to write this book?
I think in medical education there's a couple different things that are important. One certainly is the content of the education that you're giving, but the retention is every bit as important. And I've heard someone say, if you remember one thing from a lecture, 1 year later, it was a great lecture. So I've always had a high goal, high aspiration for myself. I try to have people remember 2 things a year later. Well, I think that if people can relate to specific cases and they're this type of bounce back case, then the retention is almost automatically there, because everyone fears that bounce back patient. So those are the twin goals really of my writing the book, to have good content, and we'll get into that more I think as we go through things, as well as good retention.
I see. So now that I've read this book, and I feel like I'm an expert at these 30 cases, right? So if I go through this book and I know how to identify the issues with these 30 cases, but I just want to know, and I'm going to ask you and I'm going to ask some of the chiefs, what in general, though, is a high-risk case, and how do I identify not just these 30 cases, but all high-risk patients in general?
Well, that's a perfect question, because these are unique cases, and they're not what I call, sexy emergency department cases, like through the windshield or, a temperature of 104 and a blood pressure of 60. These are the hardest cases that we see, because every one of these patients got sent home. So obviously, those people looked well enough to the providers to send them home. That's why these cases are important, because they're tricky. They're patients that stand up and shake your hand and say, Doc, I've been waiting here for 4 hours, I'm ready to go home, and you say, fine, then we'll send you home. But the lessons with these cases are so profound, because really the goal of this book is to have people realize some of these red flags and then really hone in on the history and physical. So not doing extra testing or all kinds of diagnostics at admission, things that could possibly harm a person because of over-testing, but to actually say, hey, there's something about this patient that requires me to do something further. For example, go back and get better history, maybe repeat an abdominal exam, make sure the doctors and nurses' notes correlate. And so if you look at SCLAR's data and you extrapolate that out, each of us will send home during our emergency medicine careers 17 patients during the 30, 35-year course of our careers who will die an avoidable death within 1 week of emergency department discharge. And they aren't the patient with the blood pressure of 60. They're patients that are well-appearing patients, and those are the trickiest patients, and that's what this book focuses on.
I think that's a scary fact for all of us. I want to kind of pitch it over to the chiefs. Maybe I'll start with Zach and say, how are you going to identify some of these high-risk cases kind of moving forward now that you've read this excellent book?
Yeah, so I agree, Mike, that these are tough cases, and I think the case that you wrote that brought this to my attention the most was the woman who didn't speak English, and she was pregnant, and I forget all the details, but it was, and she had multiple visits, and there were multiple providers, and I thought the doc in that situation did a great job documenting all of the issues that kind of went into that. And so some of the things that I think about, and from the book, that make things difficult cases, or if the patient is upset, if obviously if they're a bounce back. I mean, that's the kind of the point of the book. If you're seeing them on the second or third visit, kind of say to yourself, what are we missing? Obviously, any abnormal vital signs. We talked about extremes of ages, difficulty obtaining the data, like we talked about. If there's a language barrier, even our best solutions to language barrier today are not great, and obviously the high risk complaints that kind of come up a few times in the book, chest pain, abdominal pain, and kind of all the different ages and presentations of those issues.
Yeah, that's exactly right. And I've identified, I think the way that you can really look at things is two different groups of people. A high-risk complaint with some diagnostic uncertainty, or a patient with grossly abnormal vital signs, specifically undiagnosed or unexplained tachycardia. And boy, when you have those kinds of patients, and it's not every patient, it's probably just a few a day, but yeah, those are the ones you want to focus in on.
Yeah, I agree. I guess I have difficulty, and I'm wondering, so you're seeing these patients who are what you would consider maybe high risk, they want to leave. What are some charting tips I want to ask the chiefs that kind of you would use from this book to sort of protect yourself and make sure that you're still trying to provide the best clinical care? So maybe I'll ask, how about Tamara? Like, what are some charting tips you've learned?
So I think all of the cases in this book, they really spoke to me. But definitely, we oftentimes do things, and because of how busy we are in the emergency room, may not accurately document all what we're doing. But I think from this book, it's very, very important. If a patient comes in with a particular chief complaint, you want to make sure, at least for that system, that the patient of their primary complaint, to do a very thorough physical exam and history pertaining to that particular system that the patient's complaint is. If there are any abnormal vital signs, like Zach mentioned, then definitely trying to find a cause for that and making sure that you document based on your history, your physical, or even your diagnostic workup to explain those abnormal findings. I think this is really the biggest thing that spoke to me throughout the book.
Tamara, that's exactly right. And those types of focused exams based on the chief complaint, it's surprising when I review charts for medical legal consultation, it's surprising how often with a neurologic complaint, such as so many that we see, headache, numbness, dizziness, back pain, even weakness, it's surprising how infrequently there is a neurologic exam on the chart. So we get so caught up in all this stuff we need to put out there for billing and level of review of systems and all this, that sometimes just focusing on what the patient came in with is the best medical legal protection we have, is getting it right.
I think one of the things that I really looked at in the book was the using the MDM, the medical decision-making note, and I've really, since reading the book, I've really tried to focus on those notes, making sure they're time-stamped, and really kind of my thought process, even if it's incomplete at that time, I think that each one of those little notes don't take that long, and they really provide kind of my thought process to discharge or to admission.
Yeah, without a doubt, that MDM part is so important, especially when you have one of those patients with the high-risk complaint, the diagnostic uncertainty, and you want your chart really to flow. I mean, you're making an argument in your chart, aren't you? So it's not necessarily an argument for the jury, but maybe it's an argument for yourself that that patient is safe to send home. Obviously, these patients all got sent home. So, and again, we're not focusing on that, hypotensive crashing patient. Those are the ones we love to. I mean, the STEMI patient is our easiest patient, right? You have a diagnosis, they're going to the cath lab. That's the easiest patient we have. But these are the tougher ones, the ones that there's a lot of subtlety to. So that MDM section is, just like you're saying, this is an argument that the patient can go home, and it should flow. So the data needs to support that argument that you can put in the medical decision-making part. And so when I write that out, one nice thing about doing it in real time is, I always say this, that if you can't convince yourself that the patient could go home in the MDM, there's no way you can convince a jury. And so that's sort of your last level of safety, isn't it, is to actually put down the thought process that you have. And if it doesn't really even feel right to you, it's just sort of time to go back and do a reassessment, maybe have the patient walk, maybe observe them longer, start from scratch, something like that to make the patient safer.
I have a question for the chiefs here, and Mike, feel free to chime in. And when do you guys usually write your notes, and do you feel like it matters when you complete them? Like, let's say some of you might write your notes 72 hours later. You have like that 72-hour window before your admins start emailing you that there's some uncompleted charts. So when do you guys usually write your charts? What's sort of your approach to that? And maybe, Mike, you can chime in on as far as if those are good practices or not.
Yeah.
Maybe, Maggie, I'll ask you that. I'm going to put you on the spot.
Well, I'm sure my program director would have different things to say, but no, I definitely try and complete them before I leave. I think it's the safest thing to do, and I think it's important to kind of release that cognitive load before you leave the hospital. It is easy a couple days later to convince yourself differently about patients and kind of forget things that might be important.
That's a really good point, Maggie. I totally agree, because I know your brain is probably younger and more supple than my aging, shrinking brain. But keeping track of like 5 85-year-old women with weak and dizzy, and one has some chronic runny nose with a Kleenex in her hand, and the other one has like an amputation of her leg, or there's no way that you can remember those things several days later. And then you even get to that next level where a bad outcome. And just completed today a program for MRAP that's going to be on in July of a patient who had a bad outcome, and the final completion of the documentation got done after the mid-level provider knew that the patient had expired in the ICU, partly sort of in some ways due to the a lot of different factors, but some was not as timely of care as otherwise could have happened. But after they knew the outcome and they're doing the documentation at that time, it's very difficult to objectively do that documentation, to not sound defensive, and to put everything down that you should have. So I try, not on every case, but on those few select ones where I think there could be a bad outcome, just like I think Zach was saying, right, to put things down in real time, to date and timestamp it, and then you can sort of read through the medical decision making as you go through. And that's really just a few, 2, 3, 5, whatever patients a day that you need to do that on. But those are the ones I think are really important in real time to get stuff down.
I think that what I try to do is get my MDMs done in real time, as much of the HPI as I can, kind of right off the bat, and then I'll go back and fill in some physical exam and review of systems later. Still trying to finish that day if I can. Like Maggie said, I think it's best to kind of finish up before you go home. I think a lot of us chose emergency medicine because once you're home, you're home. So I still try to do that, but.
Yeah, I think it gets kind of tricky, especially as an attending. Now that I'm even as a, technically I'm a fellow, but I'm clinically an attending, so I have to sign charts for patients who I've never seen. Like 3 days later, I was asking Mike about this. You will all be attendings next year in some way, and you might have NPs or PAs who are seeing patients, and you've never seen these patients, you never met them, but you have to kind of sign these charts. Mike, I want to ask you just once again, sort of for the group, what should we do as far as our documentation for these patients who we've never met, and they're going to be coming to our in-basket?
So it varies by state, and I was gave a couple talks at AAEM in Las Vegas just a couple of days ago, actually, and someone asked the exact same question there also, because this is really tough, and there's so many more patients that are being seen by level providers these days. But if a mid-level provider can function autonomously and see patients on their own without having to have collaboration with each patient, there still is a need for a supervising physician. But I don't think that there's a real clear answer, because we all get this pile of charts and we all sign them off, and very few of us have seen each of those patients or reviewed their records. So, I don't think there's a perfect answer. It probably varies a bit by state, but in the end, what I would encourage all of us to do is whenever a mid-level provider has a patient that they want to speak with us about, that's something they feel uncomfortable about, especially experienced mid-level provider who's been doing things for years and is really, really proficient, is just to go in and see that patient and to treat that with a no questions asked type of response. You don't feel comfortable with this patient, I'm in there, I got your back, I'm going to see that patient.
Yeah, that's probably the best advice on the topic. It's just kind of hard to do sometimes, but I think it's something we should all strive to practice. One question I'll put it over to Lee and Tamara, feel free to chime in too. What were your guys' most noticeable cases reading this book?
Yeah, so first of all, Mike, thanks so much for coming on the air with us. We really appreciate you being here and absolutely loved your book. So I'll tell you that one of our newer attendings has told us that this book should be required reading for all second-year residents who are just at that point in their residency where they're starting to get confident enough in their base knowledge and maybe stretching the limits a little bit too much. So it helps kind of rein in your sense of what to look out for. So thanks. I don't want to say I've lost sleep, but the case of the young woman with the carotid dissection obviously is a very profound case, a very sad case, and one that since I started reading it maybe 3.5 weeks ago has been on my mind the whole time. I've seen since then probably dozens of patients with headache, and I certainly approach them differently now. I know that in your afterword in the book you mentioned that you do too as well. So that was certainly a humbling case that reminded me of the importance of a good neuro exam. And I think another perspective on that is that when you review charts in retrospect, you really only have the chart to look at. You don't have the patient, you don't have the experience, you don't have the conversations. And you reference in the book a couple key learning points like read the nursing notes, see what the nurses are saying, and be aware of the vital signs. If the blood pressure is 70, it's probably worth commenting on that at some point. I think that's really important, and I think it helps me as well realize that when I am writing my note, whether it's real time or at the end of a shift, just take a quick look through, kind of step back. Don't get in your mind of, if you don't think it's aortic dissection, that's fine, you can document that, but take a bigger look at the chart and try to put it together. So, all 30 of these cases certainly have had a big impact, but that young lady, I don't think I'll ever forget.
Yeah, the interesting part about that case is that the provider, even on the bounce back, was thinking, oh, this is a stroke. But, that's probably not the most common thing in a younger person. So when you have a symptom that sounds so typical, you just have to expand your differential depending on the age of that patient. And the third bounce backs actually just came out in the spring, the pediatrics bounce backs, but those cases were all written by people who actually saw those patients. And the interesting part about that with a pediatric book is that, and just like this case that you talk about, it's really important to have a age-appropriate differential diagnosis. And for that woman, she was a young woman, and an ischemic stroke certainly could be going on, but then you think of the other, like a carotid dissection, would be something else that you think about a little bit more in a younger person. So yeah, that case struck home to me also. And again, not to do extra testing and to be getting CTAs to the neck on every single patient, but just to expand your differential and to consider those things in your H&P. And almost all the time, you can be able to rule it out on your H&P.
Great, thanks.
So I think there are many cases I could pick, but there are two in particular that resonated with me. I think the second case, where there was a young man who came in with abdominal pain who ended up having appendicitis on his second visit. It seemed like everything was done right. I mean, they probably did not consider torsion in their differentials initially, but the history was good, the physical exam was good. But where the physician messed up was giving adequate follow-up instructions, and that really shocked me because I felt like, okay, I usually tell them if you get worse, come back or see your doctor in a day or two, but I don't really give it much thought into the exact time. And you read the textbooks and it gives the pathophysiology and the etiology and everything, but there is never a lot of instruction as to when should a patient ideally come back or follow up. And then the second case that I think that really spoke to me was the patient who came in with recurrent headaches, and after I think 3 or 4 visits, the physician decided to ask about where the patient was from, found out he was from Africa, had HIV. I think that, a patient comes back so many times, just knowing that we need to ask for the additional questions or additional workup to broaden our differentials a little bit more. These cases, I think, were the most impactful for me.
Yeah, I'm glad you mentioned that last one. I've thought of that one so many times. The other thought, and you sort of nailed it exactly what the thought was, that the fact where he was from, again, expanded the differential for that patient. And then in addition to that, the other thing is weight loss. And this guy had headaches for 30 years and was slow. It's so easy for us to blow that off. Then why are you in the ER now? But giving him a little bit of the benefit of the doubt is to say, well, there's obviously something different. You may be asking that question, what's different about this headache today? But he had, I think it was 24 pounds of unintentional weight loss, and he had undiagnosed AIDS, and he actually presented with cryptococcal meningitis was his initial presentation. So again, that's one that would have been tough, except for these few little things, and it really speaks to the difference, I think, that standard of care was practiced, but excellence in care was not practiced. And so that's what the goal really is here, is to go from standard of care to excellence in care. So I'm glad you brought up those 2 cases, because they're excellent ones, and you nailed it with both of them.
I have a question of something that Tamar brought up. So one thing that I had a little issue with reading the book was the time for follow-up. There were a few cases where you mentioned, or I think it might have been Greg Henry mentioned, follow-up in less than 24 hours for some abdominal pain complaints. And the issue that I have is with my patient population. I work in Philadelphia, pretty poor patient population. A lot of them can't see a doctor within a month. To tell them, oh, please follow up with your doctor in a day, even that seems a little crazy. So I was just wondering what your thoughts are on that, and how do we deal with that? Because ideally, I could tell them in their chart, and I can write in the chart, please follow up in 8 hours for a recheck. But I know that that's not going to actually get done or happen.
Well, that's a really good point, and that speaks to a lot of things. Evaluation of low risk chest pain, which we spoke about in Las Vegas, and a lot of types of complaints. And so I'd just give, first of all, a summary of, and this is paraphrasing Greg Henry, is that aftercare instructions need to be 2 things: action specific and time specific. So if you want to try, and look, it's Philadelphia and certain patient populations for follow-up, you're just not going to be able to do these types of things. However, say you have a patient, and this is a 14-year-old who has 6 hours of right lower quadrant abdominal pain. We'll make it a male just to make it a little bit easier and decrease the differential just a little bit. And you feel this patient might have appendicitis. He doesn't have a fever yet. Maybe he has nausea, maybe vomited once. And you feel, because of the data saying that only 2% of patients rupture at 36 hours, that you feel this patient can have some clinical evaluation, because he's had this pain somewhere in the past. Maybe he has stress, or maybe he has constipation, or one of those things. Well, if you don't have access to an ultrasound and you don't want to provide radiation to the patient, then with this one specific type of patient, what we would say is come back to the ED in 8 to 12 hours. And what I would say, if you have any pain whatsoever in, say, 12 hours, come back to the ED. So then there's still 18 hours, well within the window when you'd expect rupture, and then come back immediately with fever, worse pain, recurrent vomiting, those types of things. So as far as that follow-up goes, hypertension or headache or whatever, I'm not that concerned after we've excluded the bad stuff that they see a primary care doctor. But I think one of these time-specific type of diagnoses, maybe that follow-up would be through the emergency department. Not probably the best for flow and throughput, but it might be best for patient care.
Mike, do you think that people will self-select out from their return visit, even if they're having some pain, because they generally feel like they're getting better, which would exclude a good proportion of patients who are probably well?
So this is sort of funny. We don't own any cats, but I'm guessing that people that own cats, they get bit and scratched like all the time, you know? And so the incidence of infection that we would quote, and whatever the number is, like 20, 25%, whatever, 17%, you know, high enough that you'd always want to prophylax a cat bite. It's not quite as high in patients who don't even come to the emergency department in the first place. And so in that same way, I think that when we tell a patient with, for example, lower risk chest pain, we're going to arrange this type of follow-up for you, I think that a lot of those patients do self-select for their own follow-up and say, you know what, even though there's a 100, 1 in 1,000, you know, with the data that we have, 1 in 2,000 chance of something bad going on after the initial ED tests are negative, they say, you know what, I'm comfortable with that risk. And the fact is, if you, Lee, or I were in the ED with those complaints, we might be comfortable with that risk also, because following up with a primary care doctor is sort of a hassle.
Right.
I think that's exactly right. That's a good point.
I'm curious if any of you guys have had your own bounce backs, and maybe after reading this book, how you think you might have changed management or any kind of red flags or mistakes that you would correct, at least if it were to happen again. Maggie, maybe we can start with you again.
Yeah, so I actually, one of the most difficult patients I've ever had, one that kind of sticks with me every day, every shift I think about her, was a bounce back that was not my own. But she had been seen a few other times and ended up passing away. So it just, I think one of the things that reading this book and thinking about that case does for me is make me just stop and realize sometimes when you're having a rough day or you're seeing extra patients more than you feel comfortable with, or you're frustrated with the people upstairs, whatever, just stop and kind of say, okay, I got to focus on this one patient right now. That's something I've been really trying to work on over this last year, especially since as being a chief, you're supposed to kind of run the room and teach the med students and all of these things that are kind of new, and you want to be the best at all of them, but at the end of the day, the most important thing is making sure to make that right diagnosis, or at least to make the safe diagnosis.
Those are the patients that we need to say, I'm dropping everything and I'm going to see this patient, because being like 98% right, not quite good enough. You know, you can't like get like 29 out of 30 patients right on your shift every day. That's not quite good enough. So yeah, when you have that one patient, is say, look, this is like a 4-alarm fire. I need to go in and make sure I devote the time and sit down and see that patient and evaluate them like they deserve based on the seriousness of their complaint. Good point.
So the bounce back that I remember the most, I think you highlighted it well in the book, is the patient with an abnormal vital sign. I think I had a patient who had tachycardia, and I tried to blow it off. I'm like, oh, she's just in pain, and I'll give her some pain medication, and I'll send her home. But really trying to dig deep to find what are the causes of the patient abnormal vital signs. And then if you think you've determined the cause and you address it, then reevaluating the patient, reevaluating their vital signs, reevaluating their exam prior to discharge. I think that was something I learned from the case and also from the book.
So important. Alma Matute told me that they changed the protocol at the University of Maryland that if a patient is going home with tachycardia, they need to have a face-to-face before that patient leaves. And it's sort of a way to pick the low-hanging fruit. And you know, some people are tachycardic because they're in pain or because they are dehydrated, and that's explained tachycardia. But I'm talking about unexplained tachycardia. And we've had, I mean, I could shed our own dirty laundry, multiple patients in our own emergency department, the ones that have had bad outcomes. And it's that patient who looks well, but their heart rate is high, and you don't have an explanation for it. And again, just getting a better history and physical, getting better data on which to base your decision, make sure explain yourself in your MDM note. And again, if you can't commit yourself, then you got to go back and start thinking of some other possibilities.
I recently saw a patient with a early pregnancy who ultimately ended up being an ectopic pregnancy that ruptured, who on the initial visit was presenting without an intrauterine pregnancy on ultrasound and a beta quant of 5,000, which is concerning, had a consult by the OBGYN team who felt that she was low risk for discharge and close follow-up as an outpatient. She came back ruptured, pretty sick. And one of the lessons I've learned from a case like that is something that one of my mentors in emergency medicine who was at my institution has taught me, which is a bit bold, but something always to keep in your back pocket, which is to tell a consultant that you are now unconsulted, which would not be a common practice, but something to keep in mind that if you think the patient's sick and you think the patient needs to stay, at least for observation in the hospital because of a high-risk diagnosis, regardless of advice or impression of a consulting service, do what's right for the patient. Think about on the floor, if infectious disease is consulted or neurosurgery is consulted and they give an opinion in the chart, the patient isn't just discharged from the floor. Their opinion is either taken into the patient's management or not. So remember that as emergency physicians, we have that opportunity as well.
Yeah, the days are over of us just sort of deferring to a bunch of other folks that are smarter, right? I mean, we are the smartest people in the room. We are the people who have ownership of the care of that patient. And accepting that responsibility means advocating for the patient. And these are pretty rare situations where you disagree with the consultant. At least for me, it's like, in general, it's like, yeah, it seems reasonable. But for those rare times, I always have the ability to not click that discharge button, and they're in a bed already, and, it's still our patient, it's still my patient. So those are really, really good words of advice.
One of the Bouncebacks that I had when I was a resident, I think I was an intern, and I had this elderly male that came in with back pain, abdominal pain, and everything came back, I think, normal except for a white count that was like 16 or 15, and ended up having not a bad outcome, but ended up having something that needed to go to the operating room. But he was fine in the end. But I just remember it being a really busy day, and the patient wanted to go home because he felt better after Motrin and Tylenol, and he was just eating, walking around, and it's I want to go home, I feel better. And I think probably having a couple more reassessments, talking with the primary care doctor, looking over the nursing notes and the charting, and just having one more kind of conversation or just a couple more seconds would have changed things. And I feel like we get into these sort of high-risk situations, even independent of the case, where we just have a lot going on during our shifts, especially if it's a day where there's just everyone's kind of stretched really thin, and all the normal protocols or algorithms that you usually would use are kind of shortcutted out, and you're left with just running on this adrenaline and instinct and got to move the ED, and that kind of puts you in this really vulnerable position. I think one of the things that I've learned since then is when it's busy, I try to go slower, at least with my mental processes. Maybe physically I'm moving fast, but take more time thinking and less time doing all the other stuff that can wait. So that's kind of my lesson. I feel like in this book, you've given me a lot of extra pearls to add on to that. But the main thing is, caution and being humble and kind of understanding that you're in a vulnerable position as a provider, and you're going to miss things, so it's kind of tough because you don't want to be that doctor who's ordering CTs on everyone. So it's just really tricky to me. And I want to say, thank you to Dr. Michael Weinstock for being here today, and thank you to the Chiefs. Before we close out, I just wanted to know if anyone has any last-minute comments or questions before we wrap up.
One thing that I would say, if I could just put this in here, is, I don't want to sound like a broken record, but we don't want to practice defensive medicine. And I'll paraphrase Mel Herbert, who said, if you have a high index of suspicion for everyone, pretty soon it's just an index of suspicion. So you can't be paralyzed. We need to balance throughput, patient safety, and patient satisfaction. Those are the three things we're trying to balance through our whole day when we run the room. So the one phrase that I like to think about when I am approaching a patient or approaching one of these situations is, and I like to say, I don't want you to practice defensive medicine, but I want you to document in a way that's defensible. So when you have a chart that flows from beginning to end, and it's an argument for why you can send that patient home, why you think that patient's safe, that will all roll together to include patient safety. I think throughput also, And if you get it right and you get them in and out pretty quick, satisfaction. So sometimes you can balance all three of those things by thinking that in that same way, not to practice defensive medicine, but to document defensively.
I think that's a great point to end on. And I want to say thank you again to all of the chiefs who are here today. I hope this was educational for you all. And thanks again, Dr. Michael Weinstock, for being here. And I really want to encourage everyone who's listening and reading to get this book. It really is a must-read for not only emergency medicine residents, but NPs, PAs, attendings, fellows, students, anyone who's going to be documenting in a chart, having their name on a chart, taking care of a patient, and wanting to do all of that safely. So thanks again. I think we all learned a lot, and we all appreciate your time. I do want to say that March, we're going to be having another book club. It's going to be Steal Like an Artist. We're actually going to be having this at as a discussion at Courts. It's going to be a live book club. That should be very interesting. And without further ado, I just want to say thank you all again for tuning in, and be sure again to check out the blog post written by Zach Reisler. So with no further ado, thanks, and see you all later.
It's been an honor. Thank you so much.